Good morning to everyone. I am Dr. Vezzani, come from Parma in Italy, and I am the Vice President of Southern Europe. So today we have a session about gender. Gender is one of the most significant social determinants of well-being for all people. However, gender inequalities are present in all societies in terms of power, resources, rights, norms, and values, and the resulting social organization are structured in a way that negatively affect especially the health of girls and women. Many international organizations, such as United Nations, you know that yesterday we were in the United Nations, and we see that many speakers speak about gender medicine. So also MWIA has the commitment to spread gender medicine. Now, today, we have the opportunity to listen some speakers about some aspect of gender medicine. Well, with me, my co-chair is Carl Nelson. Please introduce yourself.
Hi, I'm Dr. Kari Nelson. I'm a vascular and interventional radiologist from the University of California, Irvine, where I am a medical director and chief. I'm an associate clinical professor of radiology and urology. I'm a member of the Women and I, our governing council for the Society of Interventional Radiology, and I co-founded our local AMWA chapter. It's a great honor to be here, part of this amazing meeting. Thank you.
Thank you. Well, and now this is a great honor for me to introduce Dr. Bettina. Oh, please. Okay. Please, come in, Coco, and introduce yourself. Please, come in. Yes. First. After I introduce Bettina.
Okay. Good afternoon. I'm one of the moderators this session. I'm Dr. Bong-Ok Kim from Korea. I was the organizing chair of the International Congress 6 years ago in Seoul, you may remember. And I'm the immediate past president of Korean Association. So I'm very honored to be here chairing this session with them. Thank you very much.
Thank you. And now, Dr. Bettina Fleiderer, our actual president in MOIA. Please come in and present your speech. We are friends, and it's very great work that Bettina done in these 3 years for all of us.
Thank you so much tonight. Yeah. Beside being president of Medical Women in the last 3 years, I'm specialized in gender-sensitive medicine. And I'm teaching that and developing training materials. And I'm also being a global health expert. So of course it made sense to look at this topic. Does it make sense to integrate sex and gender aspects in global health programs and research? And I want to share with you what I discovered while researching this topic. As you see here, there had been some reports which was published 2018, and it actually talked and looked how many of these global associations have female leadership. So they were investigating, what do they think about gender? Do they have any programs related to gender? Do they think it's important to integrate gender in their program? And I'm going to share with you what they discovered, and it may be a little bit disappointing because too many of those handing out money, looking into global health issue, don't consider sex and gender aspects to be of importance and save talking about women on the leadership level. And as we all know, You know, it makes a difference if one leads and has some say what's going to be investigated and researched, and this is a problem. And it was last year a report. He says, you know, women are the very busy aunts, you know, just doing the work, and a few guys on top, looking what the aunts are working on. And they say that's time to change. But this is actually the situation. Very briefly, I don't want to go too much into detail because the people following after me are going to more into detail, but just to show you that sex and gender has many aspects and that it makes perfectly sense to integrate this in global health. You know, it starts from hormones and it goes to family structures, social systems, relationships, and access to health care. This is a gender aspect. And when you just start looking into access to health care, you will see that this is a really gendered issue because mostly women don't have adequate access to health care in many countries. And this will affect health. And thank God there had been some journals now realizing this, and this was just last year, an editorial, and they said, okay, sex and gender reporting in global health, new editorial policies. And they really pointed out the first time that the authors publishing papers in BMJ Global Health encouraged to use sex and gender equity in research guidelines for reporting sex and gender information and in study design. And I think that's a breakthrough because it's the first of time. I mean, I would have preferred them to say not encourage because it's still sort of a voluntary thing, but at least it has been at the first time at least addressed that it's needed. So why it is so important to change this policy, to make it mandatory, that, you know, you will only get published if you integrate it and not, you know, it may be good if you do, not you must in order to get published. And I just draft a few of the special challenges in global health. In low-income and middle-income countries, there is even a greater need than in high-income countries to ensure that limited resources are used most efficiently. And this is a gender thing, to be very honest. And if you just don't take gender into account, they're not really distributed efficiently. Gender inequality has been shown to be greatest in many resource-poor environments and through disparities, allocation of household resources, medical care, and education. So you see just the fields where there's a lot of problems there and needs to be addressed and which hasn't. And much of these research undertaken in global health area is not really well understood. So in order to distribute things, you have to first understand how things work and how they relate and how gender affects it. And this is lacking. So you see, we have a lot of challenges. And just to show you, I can't go because of the sake of time into detail, and I just refer to this really wonderful, excellent report. But if you look at all this question, you see it's like less than 30%. It's not enough. Have you gendered programs? Is gender importance to your program and research designs and so on? And you see, it's really way too low. And if you look at global health and the diseases which are related to, just, you know, there are many diseases, but the non-communicable diseases are, you know, the leading causes, as you all know, in death and disability. And there are differences in the symptomatology, how they occur and when they occur, and the factors contributing to it. And this has not been, I mean, one can be happy if they say X men and, you know, so much women, but all the other factors which need to be addressed in programs are not there. There's something, it's the silent epidemic killing, that's the viral hepatitis, and it's just published this year. They're killing more people than HIV and TBC. So that's a real serious issue. And what, you know, they said they find out many things, what is happening and so on, but what was missing, they didn't have numbers, how many women and men actually have viral hepatitis. So that's interesting in this paper. And the most basic things are not really addressed, not safe any factors. So it tells you that we really need gender and sex desegregated data to really develop useful, sensible programs. And one of the gaps, as I pointed out, is that we need more to identify gaps in a more structured way, and also the role of gender mainstreaming and empowerment and equity. What role does it play? Who gets sick and for how long it gets sick? How long someone is treated or not? And this has not been really taken care of. Women are often not part of the leadership, as I pointed out, and too often gender mainstreaming programs are not sustainable. And I just found a nice quote: the UN simply must do gender better. And I think they're right. And gender is not included in the universal health coverage plans, not at the WHO priority global health standards and so on. You see, it's really a huge gap. The conclusions, I'm coming now to my end. Knowledge is present, but often neither known, like you said, less than 30%, or even if known, not considered. Critical research design should include sex and gender aspects, otherwise I think they're meaningless, in my opinion. Development and implementation of gender-specific preventive and treatment strategies on a political level and community level needs to be addressed and integrated as well as in education. And gender-sensitive medical research is unfortunately underfinanced, locally, nationally, and globally. And this is a problem which needs to be addressed and should be changed. And gender-sensitive medicine must be taught at medical school at this level. And last but not least, MWA must play a strong role in advocacy and addressing this on a political way, I think, at the UN and WHO to make sure that this gets integrated in these gender aspects in all these WH programs, and I think that is something we need to do. And first, the recommendation is increasing the number of women in decision-making bodies on global health level, joining networks, and I think then we're making progress. And I thank you very much for your attention.
Thank you very much, Bettina. We made the discussion now. We have 2 minutes for the discussion. Have you some question about the Bettina presentation? Bettina, I have a question for you. What do you think that the NWIA may do to spread gender medicine? And it's important for our association to make this.
Well, I think MWA must first start educational programs to really bring the gaps and the challenges more to the attention of the members. I think we need to support existing teaching platforms and materials, to do workshops, to spread it, and we have to work on the political level, on the national association, because I feel our members have the most important role too. If they go to their governments, in their medical chambers and say, we need and want to have this included, and put some pressure, this would help as well. So I think it's an important role to sensitize and be advocates of change for our members, that they get more active in this respect. And I think that I see our really major and important role to do that.
But I think that the NWIA role may be also to inform women,
Yeah,
because a lot of women doesn't know the problem.
Yeah, that's what I say, it's advocacy. So we should speak out as organization, make statements, ensure that we have sessions on that at our regional meetings as well, not at the international, but on regional meetings, just to make sure. And I think what is very important, that the funding policy changes on the national level as well. So if this is not included, then you get not funded. And I think that is a major step, because money always counts. So if you don't get money, you do it. And I think that's the way to go. Thank you.
It is my pleasure to introduce Dr. Antonella Vizzani. Dr. Vizzani completed her medical school in anesthesia critical training at the University Department in Italy. She entered clinical leadership early as Assistant Medical Director of the Emergency Department, followed by Chief of the General Intensive Care Unit. She then moved on to Assistant Medical Director of the Cardiac Department, and since 2012 has served as the Chief of Cardiac Surgery ICU at the University of Parma. With funding from the Council of Ministers and the Department of Equal Opportunities, she's educated and trained hospital health personnel to receive victims of violence. From 2016 to 2019, she served as the MWIA Southern Europe Vice President and Chief of the MWIA Research and Scientific Committee. And in December, she became the President of the Italian Women's Medical Association. Please welcome Dr. Vizzani.
Thank you, Carrie. Very big presentation. Okay, now I will show you a study about sex difference in quality of cardiopulmonary resuscitation. So, high quality cardiopulmonary resuscitation, with correct chest compression, ventilation, and early defibrillation are recommended by the International Commitment on Resuscitation Guidelines as a cornerstone to improve survival after cardiac arrest. More awareness of how immediate CPR is performed before the intervention of the emergency team is recommended in order to increase the quality of CPR and to correct providers' misperceptions. The aim of our study was to measure the quality of CPR during the first 5 minutes of cardiac arrest using a realistic and high-fidelity simulation system before and after and BLS course. Moreover, in order to improve provider misperception, we explored the cell's efficacy to perform CPR before and after the BLS course. The study was conducted in the University Hospital of Parma, where basic life support courses, according to 2015 ILCOR guidelines, took place. Using high-fidelity simulation, the patient, we make a scenario, and we investigated how a patient is treated in the first 5 minutes after a cardiac arrest. During a BLS course, the providers performed a skill test in simulated cardiac arrest using the high-fidelity simulation, both performed at the time 0 and after the course time 1. Each participant was identified by a progressive number in order to maintain anonymity and privacy. The BLS course lasted 5 minutes, based on video recording, lectures, 5 hours, lectures, practical instructions, and the simulation on the recognition of the cardiac arrest and the reaction to BLSD events. During the simulation, there was no involvement of instructions in the scenario. Two independent observers simultaneously recorded the team performance. And the self-efficacy in performing CPR was assessed by a single item questionnaire in 1,140 participants using a 10-point scales rating according to the single item techniques. The questionnaire was proposed before and to high fidelity cardiac arrest simulation and after the course. Okay. The results show that before the training, our participants show a very bad quality of CPR. Long mean time of activation of the emergency response system, delayed defibrillation, low number of cardiac compression, low cardiac compression fraction percentage, and poor correct chest compression. In addition to the delayed defibrillation, 17% of our participants never attempt defibrillation during the first 5 minutes of the scenario. The main finding of the present study was a significant increase in the CPR skills and the self-efficacy to use them after a BLS course. The BLS course effectively improved all CPR skills. However, the correct chest compression did not reach the level recommended by the guidelines. Well, we identified also some difference between women and men. Especially chest compression fraction was very, very low in women, and the difference was statistically significant. And after the course, chest compression fraction significantly increased also in women, but the difference with men was maintained. And the self-efficacy was significantly different before and after the course between men and women. Men showed a very high self-efficacy. We studied also the correlation between age and the quality of the skill in men and women. While between men, inside men, there is no correlation between age and the skill and the self-efficacy. In women, we found that in young women, the self-efficacy increased significantly, while also defibrillation time was decreased, and also chest compression fractions was better in young men instead of compared with old women. In conclusion, high fidelity simulation seems to be an effective tool to improve the quality of CPR for all. But women show greater difficulty in performing a quality cardiac massage. Improvement in the skills and the self-efficacy after the BLSD course has been obtained above all in younger women. This has an important effect on the quality of CPR practiced in hospital, where most of the clinical teams practicing CPR are staffed by women. However, even men, regardless of age, don't reach the quality of chest compression recommended by the guidelines. when possible, and especially in refractory cardiac arrest, may be useful to use auto-pulse early. Women express levels of safety that are lower than men and more adherent to the real ability to perform CPR. Thank you.
Are there questions for Dr. Vazani? And if not, I have one. So that was significant, the difference in compression or chest compression fraction between men and women, and the fact that women didn't improve as much. Do you have any idea of why that is? Or, so one thought would be we weigh less, it's harder to compress the thorax, and we're also smaller in general. And if so, well, I'd be interested in your thoughts on that. And if so, if there were specific factors, if there are projects or perhaps modifiers, tools we could use to improve that.
The difference is significant, but the guidelines ask to us to produce chest compression very hard. So it's very difficult also for women, also for men to maintain this hard compression. So it's important that when you realize that there is a cardiac arrest refractory, to improve, to obtain autopulse, but also change the operator that have to do the chest compression. And if there is a man, use man, of course.
Thank you very much. Any other questions?
Well, now I introduce Laura Pallotta. Please, she comes from Italy, from Ascoli Piceno. She is a dentist. She works in her private office, and she also is the coordinator of the Central Italy for the AIDM. Please, Laura.
Good afternoon to you all. I'm very honored to be here in this very important MIA Centennial Congress. I have to thank all my chairs, and especially and special thanks to our president, Italian president of IDM, Dr. Antonella Vezzani. My speech concerns 4 topics based on the study and the observation of my clinical activity as a dentist, medical doctor dentist during almost 40 years. I followed the women patients from adolescence through adulthood till old age, and I have understood that dentists who take care of women oral health has to face gender-specific pathologies in addition to the common other. Let's go. The 4 topics are physiology-related pathologies, new lifestyle-related pathologies, incorrect habits-related pathologies, feminine gender-specific and more common in feminine gender pathologies related. Puberty. Several studies confirm that higher estrogen and progesterone levels induce the following oral symptoms in young girls. We can observe tooth mobility, gum sensitivity, gum inflammation, and I really observed very rarely 2 or 3 patients, young girl, 10, 12 years old, with premenarca symptoms, with a strong tooth mobility, luckily reversible, but it was an important sign of premenarca. After, we can observe a pregnancy-related gum inflammation is caused by increased sexual hormone production. Marginal periodontium is affected. Edema, pain, bleeding, pemphigoes are observed. Even pregnancy pemphigoes may be reversible, but not often. Pregnancy-related gingivitis appears around the 3rd month. gets worse at the 6 and disappear after childbirth. Some studies discuss the relationship between premature births and gingivitis due to the release of high levels of prostaglandins. Breastfeeding is another important period in the life of a woman. It's still a good practice, but it may induce gum hypertrophy and bleeding, edema, gum retraction, bone ridge modification, often reversible. Premenopause and menopause present high reduction of sexual hormones and so many modifications in the whole body and the whole metabolism, for example, for calcium, not only. Mood disorders and appear particular high sensitive dentin to thermal stimuli. Completed the overview of pathology. Osteoporosis, men and women are both affected, but it's more common in female gender. Nowadays, bisphosphonates help bone maintenance, but they have adverse collateral effects. For example, aged bone, due to vascular degeneration, they think coming from anti-angiogenetic effect. Alveolar bone exposure, rapid onset of tooth mobility, extraoral and intraoral fistulas, and many others minor signs like halitosis, extreme mobility of the tooth to the loose of them. Bronze biphosphonate related osteonecrosis of the jaws is a particular consequence of BF therapy. The major part of patients with osteoporosis are women, so, for example, dental implant rehabilitation is more complex in women. It calls for a multidisciplinary team so that appropriate protocols are followed for different kinds of sub-administration, dose, and length of therapy. Topic 2, new lifestyle-related pathology. For example, we have piercing, birth control, ovarian stimulation. Piercing represent a challenge for the dentist to take care of female oral health, because it has incorrect tongue position, tongue posture, worst hygiene, worst self-cleansing, so it complicates the maintenance of feminine oral health. Birth control and ovarian stimulation that are so used as therapy nowadays constitute an addition of sexual hormone to the female body, even adolescent. So we can see all the consequences on oral female pathology. Topic 3, borderline problems and incorrect habits related pathologies. For example, diets. We have talked in the other side this morning about obesity, but on the contrary, diet, like our colleague Di Domenico, diets, they represent a danger for especially the growing adolescents and young women. Anorexia and bulimia, that are disorders of nutrition and of modality of eating, represent another complication for female oral health. No drinking enough water. It, for example, has xerostomy, dehydration, impossibility to wear mobile protection in the mouth, and so on, and gummy disease. Bulimia and anorexia often followed by autoinduced vomit that cause irreversible enamel damage, especially on palatal tooth surface. Erosion, fragility, sensitivity are also observed. Aesthetic damage and worse self-esteem complete the symptoms of pathology. Topic 4, feminine gender-specific and more common pathologies. Dental erosion from gastroesophageal reflux, GERD, is a multifactorial pathology. And we can observe palatal dental erosion, and correct protocols must be followed to prevent related oral disease. These are some images of these irreversible damage of the palatal tooth surface. Topic 4, feminine gender-specific and more common pathologies related, for example, celiac disease, autoimmune disease in genetically prone subjects with an adverse reaction to gluten. We have progressive mucosal damage. Specific habits are necessary to prevent bad condition. Sometimes oral symptoms are discovered during oral checkup and they give alarm. So we can say that the dentist may be a sentinel to intercept this disease. Sometimes oral symptoms are discovered, yes, at the first checkup. Aphthous stomatitis, atrophic glossitis, oral lichen planus, and dermatitis herpetiform may be observed. Oral lichen planus may interest tongue, lips, and gums. Burning sensation, painful ulcers, white strips and spots in buccal mucosa are often observed. Ligamentum laxity, it's a physiological condition, not a pathological one, but sometimes it may appear as a nipple laxity. It's more common in women. It makes women more prone to all TMJ disorders. Habitual TMJ subluxation with pain or not TMJ sounds, TMJ lock may be observed. Orthodontics, last but not least, women require orthodontic treatments more often than males do. That's why aesthetics is a must for major part of them. So we have to accompany women, even in adulthood, with their desire to have a more aesthetic and more smile. Thank you for your attention.
Do you have some questions? Thank you.
Quick question.
Now, 2 questions.
Quick question. So I've seen studies suggesting that women who brush their teeth once or less per day have a higher incidence of preterm birth. Is that because there is some extra bacteria around in their mouth? Or do you think that if you brush your teeth once or less per day, that you are not taking care of yourself very well to begin with? No.
No,
Women who brush their teeth, not twice a day, but once or 0, have a higher risk of preterm birth, small babies, and early babies.
Yes, small babies. You have which age years old? How many years old babies? Since 6 years old, you can learn the babies to make by themselves, and you can observe them, watch them for 5 minutes, 4 minutes, for example, like a joke, no? This your question? I can understand completely.
No, so that's okay. That's okay. That's okay. I'll ask you
Sorry.
later. That's all right.
Sorry, give me. Thank you. Perhaps the question is more complex. It's not so simple. Allora, we can't tell that women are different to approach cavities respect to the man population. So the hygiene, personal hygiene is the same, must be the same. Yes, in order to female body has many situations in which the hormones, sexual hormones who have really a consequence on, especially on GAM and on bone metabolism, female has to know this. Number one, know this, that their different periods of their life are different each other. So during pregnant, I'd like to make a particular following and teaching to clean in the best way her mat to a pregnant woman. But the same thing is during breastfeeding or during menopause or during osteoporosis treatment. That is very important. So this is female, yes, because during my study I observed in literature there's not much bibliography on this argument, so I'd like to improve these topics that are object of my study. Women always are two different, they have two different conditions. They support in a better way the pain coming from the tooth or the gum or bleeding gum. They support. But they go oftenly to the dentist to request a visit, a control, and some teaching about self-hygiene instead of the male population.
Thank you.
Okay.
Up next, I'd like to introduce Dr. Kuku Chowdhury. She is an associate professor of medicine at the Sidney Kimmel Medical College at Thomas Jefferson University. Her interests are inflammatory bowel diseases and GI diseases that are common in women, and she is one of the leaders of the IBD program at the Thomas Jefferson University. Thank you.
I think we have to get the next set of slides. The next set of slides, please. Good afternoon, while we're waiting for the slides, and welcome to the conference. Thank you very much to the organizers for this opportunity, and I will begin as soon as my slides are ready.
Because Katerina is not here.
So while we're waiting, over the next 10 to 12 minutes, I will take you through a whirlwind tour of gender differences in inflammatory bowel diseases. Maybe I should go there. Should I go there? Where is here? They have it. There you go. All right, we're all set. So, I have no disclosures. So, I'll start with a quick review of inflammatory bowel diseases, and then we'll focus on some gender differences with reference to, intercourse and pregnancy avoidance, fertility, pregnancy, finish off with anemia and bone health in IBD, and then cervical cancer screening. So what is IBD? I know that there are very, very few gastroenterologists, if any, in the audience, but we all know that inflammatory bowel disease is an uncontrolled chronic idiopathic inflammation of the gastrointestinal mucosa. And when you think of IBD, you really should not confuse it with IBS. IBS is inflammatory, it's IBS is irritable bowel syndrome, in which the mucosa is totally normal, it just does not behave normally. When we think of IBD, we really think of two diseases, right? Ulcerative colitis and Crohn's disease, but please remember that microscopic colitis is also a part of inflammatory bowel diseases. Let's look at the main differences between Crohn's and ulcerative colitis. Crohn's can involve anywhere from the mouth to the anus. Ulcerative colitis, as the name indicates, is limited to the colon. Crohn's, the rectum is not always involved, almost always not involved, and there are skip lesions. Whereas in ulcerative colitis, the rectum is almost always involved and the inflammation is continuous. Crohn's is a transmural inflammation, and therefore these patients can have fistula and abscesses, whereas ulcerative colitis is a mucosal disease. So with this in background, with just refreshing our memory about IBD, let's go on and look at the gender differences. If you look at the epidemiology, we all know that the incidence of ulcerative colitis and Crohn's disease is on the increase worldwide. But when you look at the epidemiology, it really depends upon disease subtype and geographical region. In Asia, there's a male predominance, both in ulcerative colitis and in Crohn's disease, both in the pediatric age group and in the adult. But if you look in the West, in Crohn's disease, there's a slight female preponderance of Crohn's disease, whether it be France, the Scandinavian countries, or the United States, except for the African Americans, in whom, in the United States, the ratio of IBD from female to male is about 2:1. If you look at ulcerative colitis, there is no significant gender difference in the West and in the East. Women with IBD have a higher risk of skin and extraintestinal manifestations when compared to males. If you look at the extraintestinal manifestations in males, there are only two that are commoner than in the women. One is ankylosing spondylitis, and the second is primary sclerosing cholangitis. But otherwise, your skin and extraintestinal manifestations are commoner in the women. Women have lower rates of Crohn's disease-related small intestine surgery and ileocecectomy. But in ulcerative colitis, there is no gender difference as far as the incidence of surgery is concerned. If you look at the disease course and long-term complications in the two sexes and compare them, the data is conflicting, but we do know a couple of things. One is males with IBD are more likely to have a higher mortality with colorectal cancer development. Women, for whatever reasons, if they develop a pulmonary complication and they have IBD, they do not tend to do well. In fact, that is thought to be the #1 cause of mortality in women with inflammatory bowel diseases. But if you look at the difference in medication use or the rate of hospitalization, it is not different in either of the genders. You know, we all know that autoimmunity almost seems to be a female feature, almost. Female sex is thought to act as a modifier, almost, many of the autoimmune diseases are commoner in women. Sex hormones can also influence immune reactions. In fact, we know that estrogens may have immunomodulatory effects on the intestinal immune response. Besides that, the estrogens also increase the intestinal permeability. And therefore, many of our patients with IBD, or even IBS for that matter, experience increased symptoms around the time of menses and certain other phases of the menstrual cycle. So there is a link between hormonal fluctuations and disease activity. More than half of the patients with inflammatory bowel disease that are women complain of increased symptoms during certain phases of the menstrual cycle. Also, as physicians, we got to be aware before we prescribe estrogen-predominant oral contraceptives in these young women with IBD, because that is a risk factor for thromboembolism, especially in the IBD patients who are already at an increased risk for blood clotting. In fact, there are some studies to say that oral contraceptive use may even contribute to the development of inflammatory bowel disease, but I must tell you that we do not have clear-cut data on this. What about women? This fear of intimacy, body image, sexuality, etc. is more common in women with IBD. We know that inflammatory bowel disease is a disease of the young mainly. In fact, sexual dysfunction amongst Crohn's disease patients that are women is really a big problem. and a problem that is not well spoken and talked about in the physician's rushed visit in the office. Let's talk about fertility and pregnancy. Voluntary childlessness is very common in IBD patients. Why? They have the fear of transmitting the disease to the offspring. Fear, what will happen to my ulcerative colitis during pregnancy? Fear of the child developing congenital abnormality because of inappropriate medical advice, lots of things. And then there are some real reasons why they are worried. If you look at the fertility rates in ulcerative colitis, look at the bottom line, if there is no surgery, there is no difference in male and fertility rates in patients with inflammatory bowel disease. But for those women who have had surgery for ulcerative colitis, and we all know that the surgery for ulcerative colitis is only one, total proctocolectomy with ileal pouch anal anastomosis, for those women who've had this surgery, the risk of infertility increases 3 times. And the reason is thought to be adhesions in the pelvis. Males, on the other hand, after having the same surgery, show improvement in sexual function and more satisfaction in sex after ileoanal anastomosis. So that's the difference there. So this is what total proctocolectomy is. You remove the entire colon, you make a J pouch, which is going to be the new rectum for the patient, and connect it to the anus. Crohn's disease, if you look at fertility, overall fertility rates seem to be the same. But certain studies have shown that it's possibly decreased fertility in those women who have recurrent active disease or who've had surgery. Again, the same reason, adhesions. Besides that, there's also a decrease in ovarian reserve as measured by the anti-Mullerian hormone level in these patients with Crohn's disease. What are the medicines affecting fertility in IBD? Look at the list. It's not that long. That's the good thing. Sulfasalazine can cause a transient decreased sperm count in the male patients. In women, it really does not cause much problems. Methotrexate is the only medicine in women that we cannot give it to them if they're planning to be pregnant. And if they become pregnant, unfortunately, we have to recommend an abortion. Infliximab and other biologics are safe to be given during pregnancy, but in the male patients, they can cause a decrease in the sperm motility. Pre-conception counseling is very important. It gives the gastroenterologist time to talk to the patient and ensure that they are in remission before contemplating pregnancy. It gives time for them to talk to the obstetrician. It gives them time to tell the patients which medicine is safe and which is not safe, and most of the medicines are safe. So pre-conception counseling is extremely important from the point of view of the gastroenterologist like myself. What happens to the IBD during pregnancy? Whether you look at the Piano registry from the United States or whether you look at the European data, what it tells us is that the chances of a patient with Crohn's disease, when she's in remission and if she conceives, her chances of having a flare-up during pregnancy is no higher than a person who is non-pregnant. But in ulcerative colitis, there is a slightly increased risk of developing a flare-up. The highest risk you see in the first trimester, and I honestly think that's because many patients stop all their medications. And the second peak is postpartum. So that is something we need to talk to the patient. Please continue your medication. What is the effect of IBD on pregnancy? Please remember that there is no increased risk for congenital anomalies in our babies of our IBD patients. But there may be an increased risk of spontaneous abortion, preterm birth, and intrauterine growth retardation. Once again, the thing to tell the patient is healthy mom, healthy baby. That's extremely important. And that is why we tell our goal of pregnancy is to keep the mommy well, keep the mommy out of the hospital, keep her off steroids if possible, and maintain the medications. So this list, you don't have to know this. The only reason I put up this list is once again, you see there are very, very few medications that are not safe. Methotrexate. That's the only thing I put in bold. That's the only one that our female patients that are contemplating pregnancy should not take. What is the timing of the biologics? This is the question I often get asked. We all know biologics. There are many in the market. I'll just name a few. Infliximab, commonly known as Remicade, Cetrolizumab, Cimzia, Humira, which is adalimumab, and now we have the newer ones, the vedolizumab called Entyvio and so on, and Stelara. So remember that these can be safely given during pregnancy. Now, cetrelizumab can be continued throughout pregnancy. You do not need to stop that at all. Remicade or infliximab, the recommendation is stop it at 30 to 32 weeks of gestation and then resume it after delivery of the baby. Adalimumab or Humira, the last dose is given at 36 to 38 weeks, and in a couple of weeks you resume it. It is really safe to give. The only thing you have to remember is, for those mommies who have received biologics during pregnancy, their babies should not get the live vaccine for about 6 months to 1 year. That's one thing to know about. Mode of delivery. For whatever reason, the IBD patients end up having C-section twice as commonly as non-IBD patients. But if you really look at the C-section indication from a gastroenterologist standpoint, it is active perianal disease, and that is all. If a person does not have active perianal disease, there is no GI indication for them to have a C-section. Breastfeeding, once again, very few medications that are contraindicated. The last 3 medications that are in the contraindicated category, we don't use them that often anymore. Cyclosporin, thalidomide is not really rarely used, and tacrolimus is also rarely used because the data in IBD is not very robust anyway. What about iron deficiency anemia? You got to make sure there is no other cause of anemia, menstrual loss. You'll be surprised how many times as a gastroenterologist I get referred a 32-year-old or 28-year-old young woman for colonoscopy because she's anemic. And all you have to do is spend that 10 minutes and ask, how heavy are your menses? And she's changing her tampons every couple of hours. Well, that's pretty heavy. So make sure there's no other causes of anemia, and if they are anemic, they need to be checked, and the most common way to replace iron is, of course, oral iron, because that's easy for you, easy for the patient. But please remember that for IBD patients, especially those that have Crohn's disease, intravenous iron may be better because the absorption, especially if they have Crohn's involving the small bowel. And also your IV iron will get you at your target hemoglobin quicker. Vitamin D level is low again in IBD patients. Remember to check the plasma hydroxy vitamin D3 level at diagnosis, and thereafter every year, once a year. Finish off by AGA recommendations for DEXA scan in IBD, age greater than 60 years, cumulative exposure to steroids 3 months or longer, low body mass index, history of low trauma fracture and hypogonadism, and if they have osteoporosis, you might need the help of your rheumatologic colleagues. Cervical cancer screening, remind them. We have heard enough about this. I'm sure some of you saw that very sad movie that I saw Friday night about a person that died. Remind them about HPV vaccination. So to summarize, both the incidence and prevalence of UC and Crohn's is increasing worldwide. Incidence of ulcerative colitis is similar in both genders, but Crohn's has a slightly female predominance. Women have higher rates of extraintestinal and skin manifestations, but lower rate of Crohn's disease-related surgery. In ulcerative colitis, no difference in surgeries between men and women. J-pouch surgeries in women can increase infertility rates. Maybe a link between oral contraceptives. Be careful before you prescribe them. Make sure you ask about pregnancy plans. Continue the biologics during pregnancy. Do not forget to recommend cervical cancer screening, and remind the patients about HPV vaccination. Thank you. That is all I have.
Are there any questions for Dr. Chowdhury?
Thank you, Doctor. I really appreciate your work, and I'm currently doing research on steroids to pregnant women and also their fetus and their babies. I was wondering that you mentioned about keep off the steroids of the pregnant women. However, in some rheumatological diseases like lupus nephritis, steroid was the recommendation of drug use. So have your work reveal more facts on the effect or side effects of steroid use on IBD patients?
Yeah, so maybe I was not clear. Steroids are not contraindicated during pregnancy, not at all. We also use steroids for a flare-up. It's just that there is, if you look at the data, there is some increased risk of cleft palate with steroid use. So if you can ideally avoid it, fine, but I have personally used in many patients steroids during the first trimester, before the use of anti-TNFs. And if the patient is not on anti-TNF, you certainly would prefer not to start it during pregnancy for the first time, although I have had to do that.
Vitamin D. Is vitamin D a cause of IBD or is it the result of IBD?
Very interesting question, only because two things. So vitamin D is definitely the result of IBD, but we now, because of the absorption, because now we also know that vitamin D has an immunomodulatory effect. And in fact, low vitamin D can cause trigger of Crohn's disease. And therefore, also low vitamin D in many studies has shown that these patients are more likely to require surgery down the line. So yes, it is both a cause and an effect, and I'm glad you brought that question up. Thank you.
Good afternoon. Thank you for a wonderful talk. Two things. One, HPV vaccines in the United States has now been extended up to age 45 with most insurances. It no longer stops at age 26, so important to know. Two, in terms of the steroids, they're used by us obstetricians to help the lungs mature, so there's no contraindication. But if your patient has a prolonged dosing of the steroids, they will need stress doses at any delivery, especially if it's a C-section. Thank you so much for the talk.
Yeah, absolutely, and that's why I said steroids are not contraindicated. We use it also.
Hello, thank you for your talk. I'm a medical student, third year right now. Just for women with UC or Crohn's disease who are contemplating about getting pregnant, how would you consult them about the risks of genetic inheritance? I'm just going to speak about the difference between the two diseases, which one has higher risk and whatnot. Thank you.
So so the question is, how would you counsel a young person who's trying to get pregnant and they have ulcerative colitis and Crohn's disease? So first of all, the best time to get pregnant, not that it is always in control of the physician, is that if they have been in remission for a few months. That's one thing. The second thing is that, yes, there is a risk of transferring, but the risk is not that high. In the non-Jewish population, the risk of transferring UC or ulcerative colitis is slightly higher, whereas in the Jewish population, the risk of transferring Crohn's disease is higher. But it is not an absolute transfer. It does not follow a Mendelian dominant or recessive, and that's what I would tell them. The most important thing is to be in remission, preferably when you conceive. And start the prenatal vitamins, make sure that all their vitamin levels are good, and go from there. And not stop the medication. Thank you.
Thank you so much for this very kind presentation. And now we move on, and I call Gabriella Nasi from Rome, Italy. And she is the director. Oh, sorry. I have made a mistake. Oh, because before there is Ayuna Safira. But it's enough if we go. Oh, okay. No, okay. Is yours presentation?
Yes.
Okay.
This is mine.
You go.
Okay.
Okay.
Good afternoon, everybody. I am very honored to be here. I want to thank everyone who organized this amazing event, and especially all the chairs, amongst which we find the Medical Women Italian Association President, Antonella Vezzani, as well as everyone taking part in the event. Okay, we start by explaining what the ICA is. Firstly, the acronym stands for Diverticular Inflammation Complication Assessment. Secondly, this classification is a new endoscopic classification that was validated 5 years ago. This tool is very important because the colonic diverticulosis is one of the most common anatomic alterations found in clinical practice during coloscopy. This condition has 60% incidence in the population over 6 years old, about 20% of patients with this condition with development diverticular disease. Other than 4% of them will evolve into diverticulitis. DICA, from now on, I will call it DICA to strengthen its Italian origins. This classification was done by Antonio Tursi, Giovanni Brandimarte, whom I work with, and Francesco Di Mario, University of Parma, and most our community, they are jokingly known as the Three Musketeers. The three authors divided all the endoscopic picture in 4 main groups: location, number of diverticula, inflammation, and complication. Every group has items, and every item has a score. I try to indicate, but it's the same. For location, you have left, which is 2 points, or right, which is 1. For the number of diverticula, you have up to 15, which is 0 point, and more than 15, which is 1 point. For inflammation, you have 4 options: absence, which is 0 point, edema and hyperemia, 1 point, erosion, 2 points, and segmental colitis associated with diverticular disease, 3 points. Lastly, for inflammation, there are 4 optional as well: rigidities, stenosis, pus, and blending, which all retain a score for 4 points each. If 2 subtypes overlap, only the most severe is considered. If the sum of the score is less than 3, we have DICA 1. Between 4 and 7, we have DICA 3. And finally, if the score is more than 7, we have DICA 3. This classification was validated 5 years ago. To demonstrate that the classification is valid, the DICA group conducted a retrospective study which enrolled 1,651 patients. The result of study showed how the classification is easy to use and has predictive value. 3 years ago, we published an international retrospective study. Amongst the enrolled patients, about 60% were DICA 1, 30% were DICA 2, and about 10% were DICA 3. In relation to gender, the score showed that in the both DICA 1 and DICA 2 there is a similar percentage of female and males, about half for each. Whereas in DICA 3, there is a higher percentage of female patients, about 63%. Additionally, we found a positive correlation between DICA scores and abdominal pain, C-reactive protein, and fecal calcoprotein. The authors also found a positive correlation between their diverticulitis occurrence and recurrence. Also, the occurrence of surgeries were related with the severity of DICA score. What about the therapy? The data is very interesting. In fact, if we want to prevent the diverticulitis occurrence and recurrence, it is useful to treat only the DICA 2. The best therapy was mesalazine. Is the DICA classification easy to use? The answer is yes. In fact, in January 2018, 66 Italian endoscopists validated again the DICA classification in a real-life setting coming from university hospital, first, second, and third level hospital, and from the territorial endoscopic center. All the endoscopies involved knew the DICA classification, but not all of them used it in their practice. Thus, they were subdivided as inexpert, 31 endoscopists, namely using DICA classification in their practice from at least 3 months prior to the plenary session, and not expert, 35 endoscopists, namely not use DICA classification in their practice. The authors found a very good agreement, in the group of the expert and non-expert, meaning that the classification is easy to utilize, effective, and can be considered as standardized in its context. Looking at this result, a prospective international study was organized in order to analyze the predictive value of DICA classification to confirm the previously studied result. The study is still currently happening, consequently will only show the preliminary result. The study design was based on data already validated by previously published works. Only the patient that has been diagnosed for the first time were enrolled. Symptoms, abdominal pain, meteorism, hematochezia, which were then followed up for 3 years. But why 3 years followed up? Because as you can see, the most of recurrence of diverticulitis occurs in the first 3 years. In this slide, you can see the endpoint of the study, the inclusion and exclusion criteria, which I already previously specified. As I told you, this is an international study, as the study is still happening to this day when enrolled by then 2,250 patients. Out this sample, 60% of them were DICA 1, 30 were DICA 2, and about 10% were DICA 3. We have a positive correlation between the abdominal pain, smoking, and history of appendicectomy. In this case, in DICA 3, the difference between genders is less pronounced compared to the previous study. After 1 year of follow-up, we found the same result than in retrospective study. In fact, the occurrence or the recurrence of diverticulitis were more frequent in DICA 3 comparing with DICA 2 and DICA 1. Also, the occurrence of surgery is more frequent in DICA 3 than DICA 2 and DICA 1. Another interesting data is the geographic distribution of the therapy. As you can see, these patients are treated only in Italy and South America, whereas in the all European countries, the gastroenterologists usually don't give therapy. In a conclusion, take-home message. From the epidemiological point of view, the increase of severity in DICA correlates with the symptoms and smoking. In relation to the gender, in the retrospective study, the score showed that in both DICA 1 and DICA 2, there are similar percentage of female and male, about half for each. Whereas in DICA 3, there is a higher percentage of female patients, about 63%. And the result still has to be validated from the prospective study. The correlation found between the increase in severity levels and the incidence of complications seems to be able to provide the patient with a prognostic value for diverticular disease. DICA classification is a valid parameter to predict the risk of diverticulitis, occurrence, recurrence, and surgery in patients suffering from diverticular disease. Perhaps the correlation between the symptoms, the positive of fecal calprotectin, and DICA-3 could be an important parameters combination to decide whether a patient needs to undertake surgery. The prospective study seems to confirm that DICA endoscopic classification shows significant relationship. 1. Between severity of DICA score and severity of clinical characteristics of people enrolled, higher score likely to older age, more comorbidity, etc. 2. Between severity of DICA score and severity of symptom, mainly abdominal pain. 3. Between severity of DICA score and higher values of laboratory parameters is correlated. Thank you for your attention.
Are there any questions? Okay, thank you very much. To keep on schedule, we'll go back to the presentation we skipped, which is Dr. Einar Safieva on gender disparities in colorectal polyps. Dr. Safieva is an MD PhD who completed research on stem cell clinical significance in colorectal polyps. She's a surgeon with 20 years of experience and works in Azerbaijan, and she is a representative to the European Society of Coloproctology.
Thank you very much. Good afternoon, everybody, dear ladies. It is great honor for me to be here and to speak in front of you. Today, I would like to talk about gender differences in colorectal polyps. As we know, colorectal polyps are intraepithelial lesions that can be of various sizes. These are mostly seen in patients aged 50 and above. Colorectal polyps are not only benign tumor of the large intestine, they are also malignant precursors. About 5% of all adenomatous polyps develop into cancer. Colon cancer contains 30 to 50% of adenomas. While pseudopolyps are not malignant, but the presence of pseudopolyps may increase the risk of developing colorectal cancer. Recent studies have shown that cancer stem cells play an important role in the transformation of adenomatous polyps into colorectal cancer. Some researchers consider CD133 as a surface marker for colorectal adenomas and colorectal cancer identification. What is CD133? This is a sensitive marker for colorectal adenomas and colorectal carcinomas. CD133 is a potential TIC, tumor-initiating cell indicator, and transmembrane glycoprotein secreted is the apical portion of the surface cell. It's released from hematopoietic primitive cells and epithelial stem cells. Reports also say that CD133 may be a marker for predicting aggressive behavior and poor prognosis in CRC patients. CD133, the stem cell marker, was also associated with histological grade and size in colorectal adenomas. The study was aimed at looking into the pathological consequences of colorectal polyps, their gender-based assessment, and sensitivity to CD133. 100 patients with endoscopic polypectomy underwent colonoscopy in Central Custom Hospital in my country between 2011 and 2016. The patients, 60 men and 40 women aged above 45, had gastrointestinal disorder, bleeding, blood mucus, and constipation. The pathological classification of the polyps removed was as follows: tubular 46, tubular villous 23, villous 1, hyperplastic 13, inflammatory 16, serrated 2. The classification of colorectal polyps according to the degree of dysplasia was as follows: Dysplasia was detected in 42 patients, 14 female, 28 male. No dysplasia found in the remaining 58 patients, 25 female and 33 male. This is a chart describing polyps with and without dysplasia. In our study, non-dysplasia cases were more than dysplasia cases. Pathological classification of the detected polyps by gender as follows: tubular 46, 18 female, 28 male, tubular villous 23, 7 female, 16 male, villous only 1 female patient, hyperplastic 13, 4 female, 9 male, inflamed 15, 8 female and 7 male, serrated 2, 1 female, 1 male. This is chart pathological classification of the detected polyps in males. In conclusion, in our study, we can say that tubular polyps are more common among males. This is chart classification detected polyps in female. In our study, we just found only 1 female patient with villous polyps. Study shows that tubular polyps can develop on the both sides of the intestine. And tubular villous polyps on the left side, villous polyps are mostly seen in rectosigmoid region of the bowel. When re-evaluated, 26 of the 42 patients that tested positive for dysplasia later developed cancer. None of the 58 patients that tested negative for dysplasia developed malignant tumors. We also classified the polyp by the size, and we divide the polyps by size into 3 groups. First group, 80 polyps. Its size were less than 1 centimeter. Second, among 3 centimeters, 17 patients, and 3 was bigger than 3 centimeters. 90% of small polyps less than 1 centimeter were tubular polyps. Tubular villous adenomas usually contain both tubular and villous component, and they have 17% probability of developing into cancer. The likelihood of villous adenomas developing into invasive carcinoma range between 30 and 70%. We also try to look the colorectal polyps to CD133 sensitivity. Adenomatous polyps pathologically evaluated at Central Custom Hospital in my country were later re-evaluated as a pathology department of the Turkey Meral Medical Faculty, Erbakan University. Their evaluation started with the staining of preparation material with hematoxyliniazine. 2 groups were established with distinct dysplasia and non-dysplasia. Then all the tissue were stained with CD133 immunohistochemically. Here we can see CD133 positive stain cells are marked more darker than others. Samples stained with CD133 were examined with a Nikon Eclipse E400 light microscope. The same field was selected as possible in each CD133 stained slides. These were filmed with a Nikon Coolpix 5000 camera attached to the Nikon Eclipse E400 light microscope as the same microscopic magnification. All pictures were then transferred to PC environment, analyzed using the Clemix Vision Light 3.5 image analysis program. An image analysis process started with the lens of calibration. A Nikon micrometer microscope slide made was used for this. Analysis CD133 positive stain cells were marked with the same image analysis program. Damaged cells were not evaluated. As we found in patients with dysplasia, the number of cells stained with CD133 was 33.60 plus minus 15.22, and in non-dysplasia cases 3.47 plus minus 3.62. In our study, the number of cells stained with CD133 was higher in the tubular villous and villous polyps with dysplasia. We also looked at CD133 sensitivity by histological type, and we found that if polyps, histological or tubular villous, they are more sensitive than another type of polyps. We also tried to look at CD133 sensitivity by size of colorectal polyps, and we found that if polyps bigger 1 centimeter, they are more sensitive. And the more sensitive polyps, if they are so bigger, mean more than 3 centimeter. In our cases, about 45.6% more sensitive polyps, more than 3 centimeters. The statistical difference between CD133 expression in polyps with and without dysplasia and the high incidence of CD133 dysplasia confirms that CD133 marker is specific to colorectal cancer. Our research showed that colorectal polyps are more common among men. Adenomatous polyps are highly likely to develop into colorectal cancer. Therefore, their timely detection is important for preventing colorectal cancer. In conclusion, the identification of cancer stem cell with CD133 might be a prognostic marker in colorectal polyps. We think that the expression of CD133 could be used to determine the behavior of polyp and observe treatment response. However, it is also clear that there is need for more extensive work in this regard. This is my lovely city. Thank you very much.
That was great, thank you. Are there any questions? If not, I was wondering, what is your next step in looking at CD133? What is the next step you intend to take potentially to research this?
When I started going on.
It's ongoing.
Yes, it's going on.
Thank you.
Thank you very much.
And now, Dr. Diana Galindo from the Cleveland Clinic in Florida. She is head of sector of geriatric medicine, and her presentation is about gender difference in aging.
Hello, can you hear me? Yes. All right, okay, so let's see if we can get... So this is not working, right? So...
Dr. Galindo.
Gender differences in aging. Well, it's a pleasure to be here, and thank you for staying. It's after lunch. It's at like 3 o'clock. We should all be taking a nap. But anyway, so while he's doing that, my talk and my charge is to just address the issue of gender difference in aging. I think I'm just going... It could take a whole day, so we're just going to focus on neuropsychiatric limitations in aging. So what we know for sure is that the world is rapidly aging. In the United States, the fastest growing segment of the population are the 85-year-old and over. That's the fastest growing. And within that segment, you know, the fastest growing segment in the 85 and over are the centenarians. So we have 53,000, so we're all aging, and we better be prepared for that. In addition, the baby boomers, that's for the United States, is upon us. So every day, 10 to 20,000 individuals, baby boomers, are becoming senior citizens. And that's a big challenge for our healthcare system and for the frontline caregivers that will be taking care of these wonderful people. So my discussion would focus on longevity, frailty, social predictors. We'll talk about the differences in dementia, anxiety and depression. There are other obvious gender differences in osteoporosis, COPD, pain, incontinence, but this is beyond the scope of today. Okay. Next step. So for, well, this is just for sex. This is the phenotypical XY and XX that we're all familiar with. And the next slide will be, mine is not working. Okay. So gender is the state of being male and female, the character and the social cultural differences. There's now more than male and female, binary, non-binary, transgender, and all those issues that needs to be addressed to as the population is aging. So in terms of longevity, what's the difference between the male and the female? So life expectancy from birth for the female in the US is 81 years old. And once you reach 81, there's an additional 15 that you add if you make it. For the male, it's 77. In the UK, it's a little bit better, 83 years versus 79 years. Now, it's changing as we speak. By 2060, the rate of growth for longevity is improving for men. We have to look at why, but it's 6.9 years addition to 81.7, to 77, and 5.4 years for women. So they are catching up, but women obviously are living longer. So the survival paradox. So men are more likely to die when they reach the senior age, but women are more likely to be disabled. So in the census studies, the years spent on disability for women is about 18 years in the last chapter of their lives. So 22% of their lives is spent with disability. Now for men, it's less at 19% of their lives, or 15 years. So in that paradox, women live longer, but they do have, and the issue of disability and chronic disease is based on one or two of any chronic disease as you get older. So hypertension, arthritis, back pain, respiratory disease, frailty is more common in women than men. And women tend to suffer from cardiovascular disease, and when they do, they easily die from it. The women sort of chronically handle the consequences of heart disease or acute heart disease. So there's the resilience for women as we look at it. They live longer, they're frailer, but they stay. So it's a perception of, are women more resilient, and why? So among centenarians, the female centenarians outnumber the male 8-1. But if you reach to be 100, and there's a lot of them now that's reaching 100, 53,000 of them, and growing, they have better functional status than women. And it could be because they have more chronic illnesses as they go into the last stage of life. So in terms of mortality rates, men have higher mortality. And I see it in my nursing home, in the clinics, in the hospital. If you have a stroke or you go have diagnosis dementia, it's quicker for the men to die or pass away. And the women, after even a massive stroke, they last, they linger, but with severe disability. So they're resilient, and how do we handle this resilience and manage them well at the end of their last segment of life? So that's a challenge for us. In terms of socioeconomic status, we know that women earn less than men throughout the lifespan, and older individuals in general are more poor in terms of poverty rate than the younger counterpart. So it really is stuck against women in terms of socioeconomic status. So because they live longer, they tend to be caregivers. They're caregivers for their husbands or relatives, and they often give up work versus the men. So after 65, 70% of men would be married still, but women, only 45% of them. And 14% are widowed versus 40% of the women. So that means the women tend to live longer, but they tend to live alone. And most of the time, if you visit again a nursing home or assisted living, most of them are women that needs a little bit more care and a little bit more follow-up. Men are more literate in financial information all throughout, and so they probably have more investments in one study, and while women are more conservative. So in terms of socioeconomic status, it's really tougher for the women also. So who gets more dementia? So we know that dementia is the #1 challenge for aging. At 65, 10% of people who reach 65 will have dementia, and by the time you're 85, for women it's I think 42%, for men it's about 15 or so. So it's prevalent in all age group. It's a challenge. It's one of the things that we geriatricians should handle very, very well. And women live longer than men. So they thought that, well, there's more dementia. And when we talk of dementia, what do we talk about? What type of dementia? Usually we talk about Alzheimer's, or it's a mix of Alzheimer's and vascular dementia. So, and in both those, women have more incidence of those. So at 65, 1 in 6 of the women will have dementia or Alzheimer's, and 1 in 11 of men develop Alzheimer's. So the brain, what we know for sure is there's more brain reserve in the men when that was studied. And so we know that Alzheimer's actually occur 20 years prior to the clinical manifestation. So if women live longer, then the clinical manifestation, when it happens 20 years after you get it, is much higher. So actually, there's more atrophy in men, but the rapidity of the rapid decline of atrophy is more in women. So that also contributes to dementia. And then we know also that the ApoE protein, the carriers of that would be a high risk for dementia. But even with that, the women are twice likely to develop Alzheimer's than men who carry the same gene. So what we know also is that estrogen protects the brain, and the fall of estrogen after menopause can and has been associated with Alzheimer's disease. And those are the common theories that that we say might contribute to increase in women having more dementia. So the next one would be depression. So in depression, as we get older, but all across the lifespan, there's more depression in women also, but it's twice likely to for women to develop depression in their light stage. Anxiety, which is a comorbidity for prevalence in depression, is more prevalent in women. But the suicide rate is 3 to 5 more times successful than women. So they have a reflection of resilience again in managing depression. So they're able to survive, but we have to know how to manage them better. So what are the predictors for depression? What we know is stress, which is it does increase as our patients get older. Coping styles, lack of social support, a history of sexual assault and abuse, negative body image are predictors of depression as we get older, and these are more common in women. Rumination, which is compulsive focusing on your own negative thoughts, are more common in women than men. Estrogen depletion also, like in dementia, is thought to contribute to increase in depression, including hot flashes also. What we know is that even if there's a sense of sadness and loneliness, and that comes with the contributing factors, once we, as caretakers, caregivers, take care of their health, the issue of depression and anxiety improves. So there's a great correlation between your health status and improving your depression. So in terms of anxiety, again, it's more common in women than in men, 7% versus 2. PTSD is more common in women, 12 versus 6. PTSD in men is usually from history of combat exposure versus women who have history of sexual abuse. So we need to also ask about their social history and their concerns. Panic disorder is very prominent in women than men. Agoraphobia, or being afraid in public places, is common, 85 versus 75. Social phobia, 56 to 47. So for men to deal with stress, they use substance abuse more to cope with the stress. There is an increased mortality risk when patients have been diagnosed with anxiety, but it's only in men. Again, it shows women's resilience in terms of going through it. We need to just step up and handle it better as physicians. So it's not really a conclusion, but to just go through what we have to know as women gets older and we know the differences, that aging is a global phenomenon that requires international, national, local coordination in terms of healthcare. We cannot do it without recognizing gender differences in different aspects of health. I did talk about neuropsychiatric, but there's more in terms of us being aware of the differences. Gender-specific medicine, which is a black hole really in taking care of aging patients, plays an important role in comprehensively addressing care for our older adults. Thank you very much.
Any answer? One question.
Thank you very much for your nice talk. And I have one question. When you compare the male and the female patients or something like that, and actually the male died earlier. So even though you compared both the population over 65 years old, yes, but the number and also the population is completely different. I mean, the male population is much, much younger than female population because they died earlier. So I don't know the values or the numbers of the percentage or something like that. I don't think we can compare directly because the population of both groups are completely different. The
Yes,
age and the number, everything. So could you explain it for me?
Yes, so when there's the Italian aging study actually that looks at it. So in terms of comparing, they have the population review of the percentage of the whole group. So I think it's equal that if we say, well, 10% of the women, or for example, 90-year-old, so 43% of all the 90-year-old, whether men and women, would have it. And only 22% of the men, you know that even if there's more women, we know that it's a more challenging problem as they get older and as we handle them. Yes, but I understand what you're saying. There are more women all throughout the spectrum of older people.
Thank you. The last question. Okay.
Thank you for your lecture. It was a very audience-friendly, and it was good to hear it. My question is, when comparing different clinical stage among the elderly, there is one in mental health that the women are extremely more common. Women have much more psychosis, especially this very late onset schizophrenia-like psychosis. And it has been speculated during the years that why is it so? I just thought that there are just a couple persons downstairs, on the side of the hall who have not that risk. So why is it so that women are so apt to get prone, even though it's a rare disease?
Actually, these are data, but we don't know yet the answer, and that's this black hole we need to know to be able to handle it better. Why is it more common in women? Well, there are theories about, the decline in the brain that I talked about, the loss of the hormone, the extraneous factors like stress, coping ability. So all of those contribute to that, but we actually don't know. And that's something that's probably, it's a good segue to look into more focused gender medicine issue.
Okay, thank you very much. There are so many students in here that I would think that this would attract them to study, do
so it's your turn
research.
to look into it a little bit more. These are just data that we have for now. Yes, madam.
Thank you for your
Please
wonderful talk. It highlights the importance of gender-specific research.
Yes.
As a hematologist, my concern with dementia and psychosis is vitamin B12, which women lose through pregnancy. They give it to their children. They bleed and their levels of B12 are reduced compared to men's B12. If you look at consumption of hematinics through pregnancy and menstruation, it's logical that women would start from a lower end of attrition when they enter aging, and I think it's something, we know that B12 deficiency is associated with vasculopathy and is a cause of 1/8 of dementia in the elderly at the moment in Australia. 15% of dementia is preventable through B12 replenishment, so that may be one of the explanations, and is associated with psychosis.
We did actually a study on B12, but it's between non-having dementia and having dementia, so it was not, unfortunately, not gender specific, but there is a big reversal on B12, and poor absorption is one issue with us, so we automatically check dementia, B12, if they have, of course, anemia and dementia. It's one of those what we call reversible pseudo-dementia that we need to address first, and I've seen it firsthand.
And they will be gender
It's there.
specific.
We need to move on. Sorry.
Yeah, thank you very much, and then I segue into gender medicine.
Okay, good.
Dr. Werbinski.
It's my pleasure to introduce our last speaker, Dr. Jan Werbinski. She's a fellow of the American College of Obstetrics and Gynecology. She practiced women's health and gynecology for 40 years prior to retiring from clinical practice in 2013. She's been actively involved in women's health. She's emerita faculty at the Western Michigan University, and she's the current executive director of Sex and Gender Health Collaborative.
Good afternoon. Thank you for staying. It's getting late. We could have a 3-day course on sex and gender differences. We only touched on a few, and they're very interesting. Last year, I monitored the same course, and we focused on GI last year. So we need more people to volunteer to talk about the other issues, because every single cell has a sex and every disease has differences between men and women. So I labeled my talk Where to Go When You Want to Know, because I just wrote a chapter for Marjorie Jenkins' new book that's titled that. So I'm getting to be the expert on resources to find sex and gender difference materials. And I always put this half picture of myself, and I think it depicts, if we only study one sex, we only get half of the picture. Let me see if I can move this. Yes. Dr. Trott is passing out some handouts that I have. I have cards for this website. Everything I tell you today is on the Sex and Gender Health Collaborative website, which is a subsection of the AMWA website. So you go on the AMWA website and you just type in SGHC, Sex and Gender Health Collaborative. Our collaborative is an umbrella organization, and our goal is to get sex and gender difference education into all medical education and clinical practice. We are an online community of educators, practitioners, researchers, students, and we would like you to become a subscriber. So if you go to our website, I'll show you on the next slide where to put in your name and your email address. That's all we need, and you'll get our updates and e-blasts about new research coming out showing sex and gender differences. Our website also has a whole set of, in this case, case studies on sex and gender differences. And we house this national SGBM practitioner registry. So if you have taken 10 extra credits, and I'll show you how to get that, in sex and gender medicine, you can be listed on our registry, which is searchable by colleagues, and it's searchable by patients, so patients can find you and know that you know more about sex and gender differences. Okay, this is the home page of our website, and I put the 2 green arrows in, and I wrote today on the right side one, because that's how you sign up to become a subscriber. We're not calling our people members because we aren't charging dues. There's no real formal thing that you have to do to be a member. But we're calling you subscribers so that when we have new information coming out, you can find out, and we'll just send you an email. The other thing that I put a arrow on is each section of our website is for different types of people who have an interest in sex and gender. So some of them are for educators. Some of our resources are for students, and we have a whole cadre of students who are adding to our student resources. Some are researchers, and some are practitioners, not just doctors, but anyone who's interested in sex and gender medicine. And the 2 circles, the Venn diagram we have, Diana explained well the difference between sex and gender. I don't have to go over that with you, but that kind of puts in a nutshell what we're about. Okay, the rest of my slides are just resources that you may or may not know about. You may know that the Journal of Women's Health now has added "and gender-based medicine" to their titles, so they are focusing on sex and gender differences. Gender in the Genome is a brand new journal that was started last year by Marianne Legato. You may remember her as sort of the grandmother of sex and gender medicine. And she has a journal that's devoted just to research results on sex and gender differences. And then the Biology of Sex Differences journal is an open online journal, and it's managed by the Society for the Organization for the Study of Sex Differences, which is a offshoot of the Society for Women's Health Research. There are 2 textbooks available right now that are pretty general. The first one is Marianne Legato's, and it is actually in the 3rd edition. The first edition came out back in 2009, I think it was. So she has an entire reference book on sex and gender differences in every organ system. And then Allison McGregor and Esther Chu, who spoke yesterday, are editors of the Sex and Gender in Acute Care Medicine. That came out 2 years ago. And that's for emergency medicine physicians, but it does cover most organ systems like Marianne Legato's does. And then there's a new one coming out. That's the one I just wrote the chapter for. This is edited by Connie Newman. I think she was in the audience back there. And Marjorie Jenkins. It will come out in 2020. It's called How Sex and Gender Impact Clinical Practice, an Evidence-Based Guide to Clinical Care. So what I'm telling you here today is in the last chapter of that book. Here's some other books that you might be interested in. There are 3 books put out by the Institute of Medicine, and the handbook is from our friends in Sweden. The Sex and Gender Aspects in Clinical Medicine is by the German authors, and then the What a Difference Sex and Gender Make is by the Canadian group. So this is to show you that it's really an international movement to talk about sex and gender differences. I wanted to tell you about this website, and that's the other handout you got besides my business cards. And this is called the sexandgenderhealth.org website. It is supported by the Laura W. Bush Institute of Women's Health at Texas Tech. And they have the best collection, in my opinion, of resources for you to actually learn a lot of different things. Their slide library is vast. They have peer-reviewed PowerPoint slide presentations on different diseases. And one of the people in the audience is submitting one on stroke. They don't have stroke yet, but they have, of course, cardiovascular. They have diabetes. They have depression, they have Alzheimer's, they have, so you can go there, and if you're giving a lecture on one of these diseases and you want to add sex and gender information, you can just download a few of those slides and use them in your own PowerPoints. They're open access, there's no cost to join and get those. The learning modules are a little bit more extensive. I teach this course at Western at the New Medical School, and I tried to teach all 5 learning modules in a 7-hour course, and I did it, but it was a lot because they're very extensive. Each disease that they cover has 3 modules with avatars who they actually follow a patient through that disease. So the 5 modules they have are on depression, cardiovascular disease, diabetes, infectious disease, and I can't think of the 5th one right now. But you can use those to teach, or you can have your students take those modules, and at the end they actually get a certificate. If they pass the pre and post test, they get a certificate that says that they took that module and that they know sex and gender differences in that particular disease. The solid blue arrow is pointing to the PubMed search tool, which the Laura Bush developed. And it's a tool that you can use, and you can go to PubMed, and it will show you only the titles that show sex and gender differences. There's thousands of them, but it's a way to search for this in the general research where you don't have to go through everything on PubMed. It teases out the sex and gender difference stuff. And a lot of their things are really adaptable to the new way of teaching with case-based learning and problem-based learning. That's just a screenshot of the PubMed search engine tools. They have a basic search and an advanced search. And if you go to the Laura Bush website, which I gave you the handout for, you can do that. There's also online medical education. I already talked to you about the ones on the Laura Bush, and the NIH has had 3 modules online for a long time that offers CME credit. And when I went to it about 2 months ago, they took that down. And I emailed Janine Clayton, who's the head of the Office of Research in Women's Health at NIH, and I asked her what happened to it, and she said they're developing a brand new one in conjunction with the FDA, and it's going to be out within the next 6 months, supposed to be. And I'm a reviewer for those, and they just sent me the first module to review on, it was actually on autoimmune disease. And I'm an OBGYN, so I really didn't think I was going to be able to review this, but it is so basic and so interesting. It's really good. It's very interactive. Each question just pops up at you, and they've got nice graphics with it. I think it's going to be a great course, and I'm pretty sure they're going to offer CME credit for that course. And of course, that credit you can use to be placed on our physician registry. I'm not going to go through all of these because these are on where that green arrow was that I showed you on our website. But you can go to our website and find all of these different institutions and institutes all over the world who are focusing on sex and gender differences. I don't know if you could read those, but I did have a handout that was supposed to be on the WOVA app that actually allowed you to just click on these and go there. These are all populated, but I see that it didn't show up. I did take a picture of it and put it in the photos on the WOVA app because that was the only way that I can do that. But anyway, you can actually find most of these on our website. These are just other places. The Gender Med Wiki, Bettina Fleiter and Antonio Vazzani are starting a Gender Med Wiki, and they're asking people to write articles for it. It's just like Wikipedia, but it's going to be just sex and gender difference information. Gendered Innovations is a really good website that's supported by Stanford University. They focus a lot on research, but it's a very good website for you. Charité University in Germany has a gender med database. At the bottom, the Canadian Institute has a really good website. And then the Jeopardy game is just fun. It's something you can do with your students. You can go to the society, the Educational Society for Emergency Medicine supports this. And you can go to that website, and it's actually a Jeopardy game that you can put in your classroom and have the students answer the Jeopardy questions. We have had 2 sex and gender health summits. I don't know if anybody here has attended them. AMWO has supported all of them. The first one was at Mayo Clinic in 2015, and then last year we had one at the Center of Excellence for Women's Health in Utah.
Only 1 minute, please.
In Salt Lake City. Oh, are we done? Okay, I think that's my last slide. I just wanted to tell you that the other summit is coming up in 2020, and that's on our website too. So present and future needs, things that you can do on every class that you attend, ask how would this appear in the other sex? Just start getting people aware. And if you're doing peer review for anything, put that down as something that they should pay attention to. Okay, I think I'm done.
Thank you for your very completely. Okay. Other questions? Only time for one question. Only one. Oh. Okay. Please set it.
Thank you very much. In due respect, with your excellent work, my question is, have we include, unless we can talk about sex and gender, unless we include men in the process, that's where the problem is.
Yes.
So in your work, have you looked into that?
The question is, do we include men in the process? And I have to tell you, we have gone through this whole rebirth. We used to be called the Sex and Gender Women's Health Collaborative. And we purposely took women's out of the title because we think it's important to show both differences, not just focus on women, although we've had men's health for 100 years, so it's time that we have women's health. But we do think it's important to show those other differences. You may not know that men are more likely to die within 6 months of a hip fracture than women, and men are more likely to die of breast cancer than women. So there are a lot of men's information that we can include in this, and I think it makes the whole topic more inclusive. I mean, we talk more about the women's issues here because we're all women doctors and most of us take care of women and see that deficiency. But yes, we are making a strong effort to include men. I just put something on our Facebook that said that men are more often to die taking a selfie than women because they are risk takers, and they're at the Grand Canyon and they're leaning over to take a selfie and they fall. So yes, we are making an effort to include men's health also.
Okay, thank you. Thank you. Thank you of you.